Topic of my today's talk is role of ultrasound in the first trimester of pregnancy. What is the first trimester? It is the first 13 weeks of pregnancy following the last normal menstrual period. Now we have three phases of pregnancy. The first one is the conceptus phase, which is from 3 to 5 weeks. Then is the embryonic phase, which is from 6 to 10 weeks. And then is the fetal phase, which is from 10 to 12 weeks. And they all fall in the first trimester of pregnancy. The objective of my talk today is the indications of ultrasound in first trimester of pregnancy, the pelvic anatomy, very briefly, very short, what you see when you put your probe on the pelvis. The technique, basic technique, ultrasound findings, a few pitfalls, and a literature review which is going to be incorporated when I will talk. It's not going to be separate, it will be incorporated in between. So to begin with, the indication of early pregnancy is to see whether it is normal or the pregnancy is abnormal. Number two, if there is any pelvic pathology in addition to the pregnancy. And that can be either in the form of congenital anomaly, there can be a fibroid which can be a hindrance to the continuation of pregnancy. There can be a pelvic mass. We have seen about 100 pelvic masses, cystic masses today. So there can be one of those. And there can be a collection of fluid, which is a very vital indication that something is seriously wrong with the pregnancy. That can be a ectopic rupture, etc. On transabdominal ultrasound, the pelvic pathology is very simple. When you put the probe, remember the probe is just like your eye. It's a window. It can only show you in which direction you put it. You face it towards an organ and that will show you only that organ and nothing else. So in transabdominal, the upper two images or all four of the images on transabdominal ultrasound will show you a longitudinal view of uterus with its parts of fundus, cervix, vagina, and in transverse view you can even see the two ovaries. And in addition to that, you should also follow the urinary bladder and the vessels close by. What is the need for first trimester ultrasound? It is to identify presence of, number one, gestational sac. If there is a gestational sac, is there a yolk sac in it? And if there is a fetus, or there are more than one fetuses, presence or absence of fetal movement and fetal heartbeat. Similarly, there can be accuracy in the dating of pregnancy. It is useful to identify uterine and adnexal abnormalities and ectopic pregnancy. So this is the need for first trimester ultrasound. If you look at this slide, you will see three images. On a transvaginal scan, this is the normal anatomy, but if you look closely, you will see that all three we are showing you different positions of uterus. Number one is the normal one. It is the anteverted. This marker nazar aa raha hai ji? This is the anteverted one. This is the straight one, and this one is the retroflexed one. All three of them are normal, but the retroflexed one can cause some problem at some time in the early pregnancy. So you have to keep this in mind. Early gestational sac visualization depends on good ultrasound equipment, very important. Vaginal or abdominal approach. If you are doing ultrasound at a very early stage, you need to go for vaginal scan. If you are going a little late in the first trimester, transabdominal ultrasound is good enough. Then is the expertise of the operator, and then is the position of the uterus, as I have already explained. It can be antiverted, straight, retroverted, antiflex, retroflex. So you have to keep these in your mind. Patient preparation is again very important. What you tell your patient is that 2 hours before the appointment time, empty the bladder. And over the next 1 hour before the examination, you ask the patient to drink 1 liter of water. अगर आप उसको कहेंगे ना कि पेशाब रोक के आना, by the time she gets to you, either she will be too much having volume of bladder, और वो बेचारी परेशान होंगी, आपको भी बड़ी uncomfortable होगा scan करते हुए. So ask the patient to empty the bladder 2 hours before, and then 1 hour before drink 1 liter of water, and by the time your scan time starts, she will have adequate amount of urine in the bladder. Because if it's too little in it, problem. Too much in it, problem. Scanning options कौन सी हैं हमारे पास? 2 options है. I've already discussed, talked about them. One is the transabdominal, which is also called TAS, and the other is transvaginal scan, which is TVS. Equipment selection and technique. आजकल we have the availability of modern equipment. If you remember people who are from my era, we used to have very simple, small and very conventional machines. Calipers we used to घिसा के लेके जाते थे. It would take a considerable amount of time in order to get a BPD or a simple measurement. But today, equipment is fast, it is fetal safe, and it has the ability of giving you the Doppler. So choose a good modern equipment. Probes में आपके पास जो option है for trans-abdominal ultrasound, you have a curvilinear probe. Curvilinear probe is curved and it has a wide face, and it gives you a little bit broader information. And the the megahertz, which is the frequency, should be from 3 to 7 megahertz. 3 means that you are going deep. Fat patient, big patient, you are going deep, you need smaller frequency. Big, thin patient, larger frequency can also work. Transvaginal probe जो है वो 5 to 9 megahertz होता है, and you use a latex cover on it because the same probe goes in and it can deposit infection. So for extra cover care, you need a cover. Warm gel, clean towels, and ensure patient comfort and privacy. This is very important. Some of our hospitals, although we have curtains, but we do not have sufficient facility to keep the people outside because there is a female inside. So be sure that you keep the privacy intact. You all know these are the 2 probes. And an interesting thing is that although इसका तो तस्वर भी आजकल की गर्मी में बड़ा अजीब है, but in winters you need to warm up the gel. So I don't know how you warm it up, but there are tools available. ये बना बनाया होता है. दूसरा बच्चों का फीडर गर्म करने का एक मिलता है. That can also be used. Advantages of ultrasound. Detection of abnormal pregnancies that are destined to miscarry, and reassurance to the patient if scan is not is normal. A normal scan जब आप बताएंगे तो वो खुश हो जाएंगे. Or if there is a detection of abnormal pregnancy, so you can do something well before time. Timing of visualization, gestational sac seen as early as during 4th week of gestation, or it may not be seen until end of 5th week. Technique की बात करते हैं जी, तो on the left of the screen you see abdominal approach, and on the right of the screen you see the transvaginal approach. Scanning technique for transabdominal is the set exam key on machine to OBS. Important. because there are parameters. So whenever you start, whichever part of the body, there is availability of this function. Either you can go to abdomen, or you can go to obs, or you can go to gynae, or you can go to urology. That gives you a better picture. So select the machine to obs, and then there is a sagittal view, and then there is an axial view. Always scan in both planes. In sagittal view, probe marker, ये बड़ा important होता है. I have seen several times, even postgraduate students, when they are asked to do independently scanning, तो वो उल्टा probe पकड़ा होता है, किसी ने सीधा पकड़ा होता है, किसी ने कुछ किया होता है. So there is an arrow on the probe. So when you are doing sagittal scanning, keep the arrow towards the head of the patient. In that case, the image will be formed. The upper end of the screen, the left hand of the screen will show you the head end, and the opposite will show you the foot end. Similarly, if you go for the transverse, bring the marker towards the right side of the patient. Yani apni tarah, you stand on the right side of the patient, so bring the marker towards your side and then scan. And with the passage of time and keep on doing it, आपको खुद से पता लगना शुरू हो जाता है कि मैंने प्रोब रखा है, नहीं आ रहा पुट्ठा है, इसको सीधा करना. And if there is no marker, no nothing, put your finger on one side of the probe, you will see the image. अगर image left side पे आ रहा है, तो that is the head end in sagittal, and right side on the transverse. For a pelvic examination, place the probe on the symphysis, a little above the symphysis pubis. This is how you do it. ये है जी longitudinal transabdominal scan. On the left side you see how it is placed, and on the right side you see how the uterus looks like. But remember, not always uterus is central. So once you put the probe, you have to maneuver it. Either you move it like this, or you move it like this. मैं नजर आ रहा है मेरा हाथ? That way you can identify the image of the uterus, and what you need to do is to have it full, complete in one scan, one section. इसलिए अपने प्रोब को वहाँ रख के सोना नहीं है. अगर आपको पूरा यूट्रस इस तरह का नहीं नजर आ रहा, तो उसको मूव करें इस तरह थोड़ा सा tilt करें, and that will give you the image. Transverse में you'll see on the left there is the placement of the probe, and on the right you have the transverse section of the uterus. Scanning technique of transvaginal scan. This gets you closer and eliminate air bubble. How you do it, the most important thing is that there is a rubber latex which has to be placed on the probe so that no transinfection takes place. And this is the probe, and that's how you put the cover on. But remember, before you put the cover on, you put a lot of gel in it so that air is removed. And this is the position for which is called lithotomy position. But remember, not always these stretchers or stools are available. So what you can do is, there are two methods. बिस्तर पे लेटा के patient को put pillows underneath the buttocks. That will a little bit elevate it. The legs can be adjusted, and this procedure can be done. So you don't need to go for this sophisticated table. You can do it otherwise as well. What some people do is they bring the patient to the edge of the bed, and then put the two legs on the arms of a chair which is at the foot end, and that also gives an access. On TVS long axis, ये इस तरह का uterus नजर आएगा, and what the differentiation is that you are closer to the uterus, so you can pick up small pathologies. This is the transverse, you are closer, you can pick up small pathologies. TVS disadvantages are short probe target distance, allow use of higher frequency probes, better image resolution, avoid problems of under or over distension of urinary bladder. You don't need to have a full urinary bladder. Rather, you ask the patient to pass the urine, empty the bladder, and then TBS is done. ये देखो जी, ये ऊपर वाले एग्जाम्पल में on the left hand side top corner you have a trans-abdominal longitudinal scan of uterus. आपको इसमें इतनी डिटेल नहीं मिल रही, but when you do transvaginal you come close to the endometrial cavity and what you do, you are picking up this small sac. ठीक है जी, और साथ ही आप डॉपलर भी कर सकते हैं। टीबीएस डिसएडवांटेजेस, एक तो ये थोड़ा सा महंगा होता है, लिमिटेड डेप्थ पेनिट्रेशन, लैक्स ग्लोबल पिक्चर। व्हेन यू आर क्लोज टू दिस योर ऑर्गन तो साइडों की चीजें आपको नजर नहीं आती। समटाइम्स इट हैपेंस दैट इफ ओवरी इज सिचुएटेड हाई अप तो ट्रांसवैजिनल करते हो मिलती नहीं, तो ऑलवेज कीप योर ट्रांस abdominal अप्रोच देयर एट द सेम टाइम। गोल क्या है जी? रूल इन प्रेजेंस ऑफ इंट्रायूट्राइन नॉर्मल प्रेगनेंसी, रूल इन नंबर ऑफ प्रेगनेंसीज हैं कितनी, एंड रूल आउट एक्टोपिक प्रेगनेंसी। ये हमारा गोल है व्हेन वी डू फर्स्ट ट्राइमेस्टर प्रेगनेंसी। तो जेस्टेशन सैक ये इस तरह का नजर आता है। इट्स एन एकोजेनिक रिंग सराउंडेड बाय अ सोनोल्यूसेंट सेंटर। 4-week gestation sac grows at a rate of about 1 millimeter a day through the 9th week. So one indication of intrauterine pregnancy is a gestation sac which has a typical feature, but remember that only gestation sac is not a 100% indication of a normal pregnancy. ये देखें intradecidual sac sign. In the decidua there is gestation sac and it's a double decidual sign, typical of intrauterine pregnancy. Yolk sac. Next structure to become visible in a normal first trimester pregnancy after the gestation sac is the yolk sac. It is a sac within a sac. So larger one is bigger and the smaller yolk sac is small. So this is a round sonoluscent structure with a bright rim and it appears during the 5th week and no larger than 6 millimeter. Maximum इसका size 6 millimeter. चलिए मैं आगे बताऊंगा कि कौन सी एक दो और चीजें इसकी खराबी को जाहिर करती हैं। Then is the twin or multiple pregnancies. When you are doing first trimester, आपने देखा gestation sac है, वो normal शक्ल का है, और उसके बाद yolk sac देखा आपने। इसके अलावा आपने देखना है कि एक ही प्रेगनेंसी है कि दो प्रेगनेंसी, एंड समटाइम्स देयर आर 3 and I was surprised. I was going through Google a few days back and I saw there was a woman who mashallah delivered 11 babies at a time. It's on Google. अच्छा, अब हम इतनी बात कर रहे हैं एक्वोजेनिक, ब्लूसेंट, हाइपोएक्विक, फलाना टमकाना, दिस इज हाउ यू डिफरेंशिएट। ये एक स्ट्रिप है विच हैज अ टिपिकल कलर, so this is called background color, ठीक है जी। The first one which is the most echogenic, the top one, this is white, very bright. In the sonography language it's called hyperechoic. उसके बाद आप देखें, this one is not visible at all, it's very subtle, and this is isoechoic. अच्छा जी, उसके बाद फिर ये आ जाए तो this has a different color. This is hypoechoic, and the last at the bottom is black. This is anechoic. तो ये समझ लग गई आपको कि hyperechoic जो ज़्यादा चमकदार है, isoechoic जो बैकग्राउंड से मर्ज कर रहा है, और hypoechoic जो उससे कम है, और anechoic जिसमें कुछ भी नहीं है, पानी जिस तरह होता है ब्लैडर में आप देखें, तो that's how it is. Fetal pole, mass of fetal cells separate from yolk sac, apparent on transvaginal ultrasound just after 6 weeks of gestation. Fetal pole goes at a rate of about 1 millimeter. ये typical साफ चीजें, लेकिन हमारा मकसद ये है कि उस gestation sac में if fetal pole is identified तो आपकी pregnancy ठीक जा रही है। ये तीसरा चौथा step आ गया। उसके बाद जनाब, this is how the fetal pole looks like. You see This is the gestation sac, this is yolk sac, and this is the fetal pole. Undervaginal scan की ये advantage है कि we can pick up the movement and the cardiac activity of the fetus at a slightly earlier time, slightly earlier. तो अगर आपको थोड़ा शक हो ट्रांस एब्डोमिनल में पेशेंट इज थिक, हैवी और नहीं नजर आ रहा तो आप ट्रांसवैजिनल यूज कर सकते हैं. एंड द अदर नॉर्मल प्रेगनेंसी इंडिकेशन इज द फीटल हार्ट रेट. हार्ट रेट नजर आ गया तो इसका मतलब है कि प्रेगनेंसी इज गोइंग ऑन फाइन. नॉट फाइन से मुराद ये है कि 100% नहीं. डॉक्टर साहबान यहाँ बैठे हैं, इन्होंने आपको बताया डॉपलर में क्या क्या होता है, क्या क्या देखना है, सब कुछ नजर आ रहा होता है. बट दैट्स अ डिफरेंट टॉपिक. आई डोंट वांट टू गो इनटू दैट. व्हाट आई एम ट्राइंग टू टेल यू द बेसिक्स. पिटफॉल्स में जी डिफिकल्ट आइडेंटिफिकेशन ऑफ फीटल हार्ट बीट. अच्छा, कई दफ़ा हार्ट बीट जो है ना वो आप नज़र आती है, आपको वो फ्लिकर सा नज़र आता है, बट इट इज़ नॉट कन्फर्म कि ये हार्ट बीट है कि नहीं है, बिकॉज बैकग्राउंड मूवमेंट एंड मैटरनल पल्सेशंस जो हैं वो ओवर इन्फ्लुएंस करती हैं उसको. तो उसके लिए एक छोटा सा है कि अगर मूवमेंट डिसक्रोनस है, डिससिंक्रोनस है, तो वो हार्ट बीट है. और अगर पल्स के ऊपर, पेशेंट की पल्स पे, मदर की पल्स पे हाथ रखें और उधर फीचर्स का फ्लिकर देखें, इफ दे आर नॉट सिंक्रोनस तो उसका मतलब है कि फीटल हार्ट बीट ही है. Attention, sometimes with normal pregnancies, fetal heartbeat not visible until a fetal pole of up to 4 mm in length is seen. Failure to identify cardiac activity in a fetus whose length is greater than 4 mm requires further assessment. ये याद रखिए. 4 mm का है, नहीं नजर आ रहा तो फिर और इन्वेस्टिगेशन करनी है. Difficult visualization, anteverted, retroverted. इसके अलावा if there is a fibroid or a pathology of the uterus which is large enough that it is compressing physically the endometrial cavity, तो gestation sac जो है वो पिचक जाएगा, तो आपको कई दफा नहीं नजर आता. Several times it happens कि पेशेंट जो है वो सोनोलॉजिस्ट, खास तौर पे कुछ सोनोलॉजिस्ट, ओके लेट्स फॉरगेट इट, जो कि देखते हैं और कह देते हैं कि जी ये प्रेगनेंसी नहीं है, वो बॉदर नहीं करते कि उसको ट्रांसवैजिनली कर लें, या क्योंकि अगर इफ द मदर इज सेइंग दैट शी इज प्रेग्नेंट, इफ द पीरियड इज मिस्ड, इफ द अदर पैरामीटर्स आर देयर, you should try your maximum to go for different ways to do it, to confirm it. Measuring gestation. अच्छा, इसी में फर्स्ट ट्राइमेस्टर में आपने उसकी डिटर्मिनेशन एज की भी करनी है. तो जेस्टेशन सैक का मीन जो डायमीटर है, मशीन आपको बता देती है कि इसका कितना साइज है और ये कितनी इसकी एज है. देन इज द क्राउन रम्प लेंथ. दिस इज लिटिल मोर प्रिसाइज. डू मेजर द क्राउन रम्प लेंथ व्हिच इज द क्राउन एंड रम्प लेंथ, एंड दैट गिव्स यू एक्यूरेट एज. कॉम्प्लिकेशंस जो है जी, फर्स्ट ट्राइमेस्टर प्रेगनेंसी कॉम्प्लिकेशंस आर कॉमन. नंबर 1 is miscarriage. 20 to 25% miscarriages are there. 1.5 to 2% are the ectopic pregnancies, and 40 to 50 ectopic pregnancies are misdiagnosed. Miss हो जाती. Abnormal pregnancy destined to miscarry. ऐसी pregnancy जो मौजूद है, but you pick it up and you are sure that it is not going to prolong unless God's will. So that you can also pick, and that is the example. For example, if you see on the left side, ये जो gestation sac अगर crumpled और इसका decidual reaction is not very strong like the one I showed you before, there is a difficulty. This may not reach the full maturity. On the contrary, sac on the right side, if you see, there is blood around it. So this is subchorionic bleed. And this is also an indication कि अगर तो ये यहाँ रुक गया तो चल जाएगा काम, और अगर ये बढ़ता गया तो फिर it's not going to survive. इसी तरह yolk sac की जब बारी आती है तो look at the yolk sac. If it is 4 millimeter, it is normal. If it more than 6 millimeters, तो ये abnormal है. या तो sustain नहीं करेगी pregnancy या उसमें chromosomal abnormalities होंगी. और इसकी wall देखें, it is thick and sometimes the sonolution part of the yolk sac is also white. ये सारे का सारा white होता है. These are all abnormal indications. Failed pregnancy, a failure to identify with transvaginal ultrasound a yolk sac when the gestation sac has grown to 12 millimeter. अगर आपने 12 मिलीमीटर का मेजर कर लिया इंट्रायूट्राइन प्रेगनेंसी में gestation sac और आपको उसमें fetal pole नजर नहीं आया, yolk sac नहीं नजर आया, तो ये sign of indication is of failed pregnancy. Evidence of failed pregnancy: absence of visible fetal heart beat, count length is 5 millimeter, so on and so forth. I will give you 5 seconds. Just go through this and I will proceed on. ऊपर नजर आ रहा है? Okay. Threatened abortion. बहुत दफा ऐसे होता है कि पेशेंट ब्लीड करना शुरू कर देती है प्रेगनेंसी में, तो फर्स्ट ट्राइमेस्टर में आपको थ्रेटेंड अबॉर्शन भी देखनी है. इसमें 25 to 40% प्रेगनेंसीज में ये होता है. एंड observation of subchorionic bleed is there, which I have already shown you, and this is worrisome sign and reduces the pregnancy to about 2/3. यानी 2/3 रह जाती है प्रेगनेंसी अगर ये चीज पैदा हो जाए तो. ये देखें, दिस इज अ मिस्ड अबॉर्शन. ये एक ही दफा देखने पे आप नहीं बता सकते. मैं तो आपको एग्जांपल दे रहा हूँ ना. यू नीड टू सी इट आफ्टर 5 days कि कोई इम्प्रूवमेंट, कोई इस तरह की चीज हुई है कि नहीं. अदरवाइज अगर इसको वैसे भी देखें तो इट्स अ क्रम्बल्ड सैक, एबनॉर्मल योक सैक, एंड यू डोंट सी एनी फीटल पोल. और ये 12 मिलीमीटर से भी बड़ा होगा. और इसको और बहुत कुछ दिखाना चाहिए which is not showing, so it means that this is a missed abortion. Incomplete abortion में you all know that there is content and it is not completely evacuated, so there will something remain in the uterus. Ectopic pregnancy एक और बड़ी important चीज़ है. ये दो तरह की होती है, एक इंट्रायूट्राइन ectopic pregnancy और एक एक्स्ट्रायूट्राइन ectopic pregnancy है. और फिर एक ectopic pregnancy है जिसमें both इंट्रायूट्राइन नॉर्मल है और उसके साथ एक बार पड़ी हुई है. This is called heterotropic pregnancy. Indirect evidence includes absence of an indefined definitive intrauterine pregnancy. Definite नहीं है uterus के अंदर, so this is an indirect sign. Presence of an intrauterine gestational sac, pseudo sac, without fetal pole, without yolk sac, without heartbeat, without etc. So this is one. A large amount of free fluid inside the abdominal cavity, which is a 99% indication of ruptured ectopic pregnancy. चलो जी 99 ना सही, 95 कर देते. इंट्रायूट्राइन एक्टोपिक प्रेगनेंसी में एक बड़ी मजेदार चीज है जो कि मुझे भी बहुत अरसे के बाद पता चली, and that was that if you measure the endomyometrial mantle thickness, अगर ये 8 मिलीमीटर से कम हो तो चांसेस हैं कि आपकी इंटरस्टिशियल या कॉर्नुअल, which is again an abnormal thing, ectopic होता है. और अगर इसका 1 सेंटीमीटर टू मोर देन 1 सेंटीमीटर हो तो ये नॉर्मल प्रेगनेंसी है इन दी फंडल रीजन. और कहाँ है एंडोमायोमेट्रियल? ये यहाँ से लेके एंड यू मेजर द एंड ऑफ द, तो ये अबाउट 1.51 सेंटीमीटर है. लेस देन 8 इज डेंजरस एंड मोर देन 1 इज फाइन. एंडोमायोमेट्रियल मेंटल थिकनेस. एक्स्ट्रा यूट्राइन एक्टोपिक प्रेगनेंसी बड़ी सिंपल सी बात है कि इसमें यूट्रस खाली पड़ी हुई है एंड देयर इज एन एडनेक्सन मास, देयर इज उसके अंदर भी एक्टोपिक प्रेगनेंसी में रिमेंबर दैट इफ यू सी अ फीटल पोल एंड द फीटल पोल हैज अ हार्ट बीट, तो वो 100% साइन है कि ये वो है. अदरवाइज फिर वही बात आ जाती है, इफ यू डोंट सी द फीटल पोल, डोंट सी द fetal heartbeat, तो फिर वही बात आ सकती है, it may be. But in the presence of history and other things, most of the times it is the ectopic pregnancy and its structures. मॉरिसन पाउच भी देखा करें, जिस वक्त एक्टोपिक प्रेगनेंसी का खतरा हो तो ब्लड कई दफ़ा हेपेटोरीनल एंगल में भी पहुंचा होता है, इतनी ब्लीड होती है। हेटेरोटॉपिक प्रेगनेंसी का इंसिडेंस जो है जी नॉन रिस्क में वो 1 in 30,000 है, असिस्टेड प्रेगनेंसी में 1 in 7,000 है, एंड इन ओव्यूलेशन इंडक्शन 1 in 900। तो आपने हेटेरोट्रोपिक प्रेगनेंसी ज़्यादा गौर से देखनी है अगर असिस्टेड प्रेगनेंसी हो या ओव्यूलेशन इंडक्शन हो। और अगर नॉर्मल है प्रेगनेंसी, किसी असिस्टेंस की नहीं आई, तो फिर इसके चांसेस 1 in 30,000। एंड दिस इज हाउ द हेटेरोट्रोपिक प्रेगनेंसी लुक्स लाइक। दिस इज अगेन अनदर टॉपिक, पूरा लेंथी है, इसके ऊपर भी बात हो सकती है, लेकिन फॉर द टाइम बीइंग this is about it. You see 2 gestation sacs, one is in uterus and the other one is in the outside the uterus. So this is heterotropic pregnancy. Conclusion, obtain history and correlate with sonographic findings. History जरूर लिया करें, patient के क्या सूरत हाल। Select appropriate equipment and technique. Technique आपकी सही होनी चाहिए, उल्टा ही ना देखते हैं सारा। Look for normal pelvic anatomy and any deviation. एक ही यूट्रस है, उसके 2-3 हिस्से तो नहीं है, कोई congenital changes तो नहीं है, कोई abnormal structure तो उसमें नहीं है। Identify number of pregnancies, then go for age of pregnancy and diagnose ectopic or heterotropic pregnancy. This is the